Hello, everyone. Welcome to the inaugural webinar of the third year of the COMMeND program. As you know, this is a program that tries to develop a network for otitis media researchers around the world. And we are so happy to kick it off with very excellent mentees that we recently enrolled in our program. And so to start off, we have Dr. Carolina Dermusa. Carolina is a Chilean ENT surgeon with a specialization in otology, and she holds a PhD from the University of Navarra. She also completed diplomas in audiology and public health, and she now holds a prominent role as a technical officer at the World Health Organization, specifically within the Ear and Hearing Care Program in Geneva, Switzerland. We've been wanting to hold this webinar to highlight the role of otitis media in developing hearing loss. And so it's about time. And we are so happy to have Carolina as an advocate for hearing loss due to otitis media. Please go ahead and put up your slides, Carolina. Thank you for giving this talk.
Thank you, Reggie, for that nice introduction, and thank you for the invitation. Let me put my presentation there, and we can start. Let me see. Can you see my screen?
Yes.
Reggie, you're ready. Yes, you can. Okay,
Yes.
So let's start then. I'm gonna take you in a journey related to otitis media and at the same time hearing loss from a public health point of view. So let's start. And the first topic to consider are numbers always. This is the bigger picture. We have 1.5 billion people with some degree of hearing loss, and from them, 430 million would require hearing rehabilitation of some kind. The gap is huge. Only 17% of people that need hearing rehabilitation have access to that. And if we don't do nothing, in 2050, we will have 2.5 billion people with hearing loss, and over 700 million will require rehabilitation services. And something very important is 80% of these people live in low and middle income countries where the access to care is even more limited. So the big picture here is most of those that have hearing loss or ear conditions can be benefited by timely and effective interventions. The interventions exist, but they are not available and or affordable for the people that need to be treated. So otitis media in particular is a leading preventable cause of hearing loss. This is important. We can do prevention on this area. So when we talk, the discussion I'm going to put on your plates with this presentation is based on chronic suppurative otitis media, otitis media with effusion and cholesteatoma. I'm not talking here about acute otitis media. Well, this is information you know. 80% of children experience at least one episode of otitis media by the age of 4. And according to recent studies we did at WHO based in GVD, over 40% of hearing loss in school-age children, that means 5 to 19 years old, is due to otitis media. And bonus track, we have 800,000 of new cases of hearing loss every year globally due to otitis media. So hearing loss is something to consider when we talk about otitis media, not just the pathology. And why hearing loss from otitis media matters? Because hearing loss matters. And address hearing loss means delay in speech and language development for children, poor educational outcomes, in the future reduced employment opportunities, and very important, social isolation and stigma. So we need to address not just otitis media, also hearing loss. When you think about any condition, any health condition from a public health approach, you will use something similar to this. This one is a little adapted for otitis media, but it's suitable for different conditions. Huh? Of course, prevention, as I said, prevention is probably the most smart public health decision you can make. It's cheap, it's better for people to prevent and not to need treatment. If you don't get to prevent, then you look for early identification. When you identify the condition is already there, well, then you want timely treatment. In the case of hearing, you will go with hearing rehabilitation, and then you follow up and make sure there is inclusion and accessibility for that person. But when we talk about a person-centered approach, considering everything, it's not that we are going step by step. We are doing everything at the same time. It's like a 3D action. It's not like I prevent first, then I go. I will have a group for prevention, a group for early identification, and so on and so forth. And I'm working in every field at the same time. So very quick, because you are going to hear a lot about this during the rest of the presentations. As you know, for otitis media, you have medical treatment. You also have surgical treatment specifically for these three conditions we are talking about today. Very important, hearing loss rehabilitation that must include always counseling, because there are several options and the person or the caregiver, if it's a child, needs to know all the options and look for the most suitable for them. Surgical reconstruction when there is a need for that. And then we have hearing devices. We have air conduction and bone conduction hearing aids, depending on the case. You can use one or the other. We have bone conduction implants, also for otitis media, and in some cases, specific cases, of course, not the majority, but you will have some cases for cochlear implants too. Said that, when we talk about equity and access, we have challenges. And the major gaps are in the workforce. We don't have enough specialists. Access to devices. Some of the devices are very expensive, and you need also, if it's an implantable one, for example, you need a surgeon trained. And access to rehabilitation services is also an issue. And the persons in low and middle income countries, which are the majority of people with hearing loss and otitis media, are least likely to receive care. So we need to think about this and look for solutions. And at this point, people is asking themselves, well, okay, Carolina is showing us the situation, but what is WHO actually doing with all of this? So the first step is awareness. Awareness provides access to services. If you don't know you have a condition that needs to be treated, you won't look for the services you need. So the first step is always awareness. And for awareness, we have several initiatives, but I really like this one, and it's very important for this topic this year. We have Working Day, that is 3 of March every year. You are not going to forget. Month 3, day 3, 2 years. So that's why that is the date. And every 3 of March, WHO prepares a theme based in evidence and in the needs our stakeholders, the member states, and our colleagues from regional and country offices fit us with the need that there's out there. And for this year, we focused on school-age children, actually. And that's why celebrating Working Day, you can actually promote access to services and to care. When we talk about the demand of services and we talk about hearing or ear, we talk about screening. When you screen, you generate a group of people that will need to be tested, completed, clinically tested, and then identify from them which will require other services. So specifically talking about otitis media, and in this case, in school-age children, we launched recently the Vision and Hearing School Screening Handbook. And you will see on the right two images. Down there, you have a solar otoscope. And why? Because, yeah, you cannot do, or according to our point of view, it's not just to test hearing. You need to do an otoscopy because otitis media is so prevalent in this group that any screening strategy must include otoscopy. And yeah, otoscopes are a problem because they are expensive and so on and so forth. Well, this otoscope is a solar one and it costs less than $20. So there are options. That otoscope was not developed by us, but the device on top of that, that represents a tablet, is an app we developed at WHO and launched recently. Ears is a free app available in Android and iOS for tablets. If you look for it in your phones, you are not going to find it. That require very cheap equipment, doesn't require calibration, and permits allowed to do a screening similar to a Swift audiometry. So these kind of tools are very useful if you plan on implementing hearing screening on school-age children and in adults too. This is useful from 5 to 100 years or more if you want. Then we have service provision. And for service provision, we are finishing the package of ear and hearing care interventions. This package is not meant to be used by clinicians or for users, people, community. It's for ministries of health. Sometimes what happens at that level is that the person that is in charge of the hearing program is perhaps, I don't know, a cardiologist that is covering many areas of health. And they don't know where to start. So this document contains technical guidance and evidence-based recommendations on the main ear and hearing conditions, the interventions needed to cover that conditions, the equipment and medicines, and the assistive technologies needed. Also, we put in the different level of healthcare which interventions must be available. So it's a very good start point for a country, for example, that wants to start with a program, or for a country that wants to improve their program that already exists. And to show you a little on how we develop these kind of documents, this is the kind of things we are, when you are not at WHO, you are curious on. So we identify a core research group for literature review and a group of experts that will give their inputs. All our groups must be transversals in terms of representation of all regions, all cultures, ideally and generically balanced. Then there is a selection, in this case, of the ear and hearing care condition based on the impact and prevalence. Then discussion with experts, they agree on our selection. Then we come to the identification of the interventions, looking for high quality guidelines that are tested by the Agri2 tool. I'm not going there, no worries today. But anyway, very serious work identifying high quality publications. And then we go with the experts again, they approve or not, or we discuss the final result that is coming to earth based on the experience of the experts. And finally, the development of the document and the launching. So as an example, for example, for otitis media, we have these 4 topics and we cover everything that is needed. This is a summary, of course. I'm talking about a document that is really a book. But for example, you will see there air conduction and bone conduction hearing aids, bone conduction implants, cochlear implants. I mean, it's not that we are working just for low middle income countries. We are doing these documents for everybody to be able to implement if needed. And you will see something similar with cholesteatoma. Actually, we decided on this in this case to separate cholesteatoma from the other diagnosis of otitis media. Talking about gaps, one of them is the insufficient and unequal distribution of ear and hearing care specialists. That is a big issue globally. Not just ENTs, otologists, of course, and audiologists are not enough. So if you say, okay, how can I solve this? You say, well, okay, more specialists. But we all know that's not that easy, you know? To have a specialist is a long time for training, and experience acquisition is another topic. It could be many years more. Then, you know, this is a free world, so you cannot force a specialist to go working, let's say, to a dangerous place where it's a war, to a place with not enough support for their families in terms of schools or access to different services, or perhaps to a place where are not enough resources for that specialist to develop in their work. But we still have unserved population waiting. And I learned this in a conference in Spain. Is the postal code curse. That means if you were born in a country or even in a state inside a country that has coverage for ear and hearing care, good for you. But if you don't, I'm so sorry, you don't get to have access to care. Personally, I cannot sleep with that in my mind. So we need to look for a way to get to the unserved population timely. And that's why we use this philosophy, which is the task sharing. Task sharing is a redistribution of tasks among health workforce teams, that these people are health workers, but not specialists. And they have training for very specific tasks, very identified tasks, and they have this a pathway very clear on how, when, and at which time to refer people. The supervision here is by the specialist, but the service is provided by a non-specialist. So at this point, some people is saying, what? This lady wants to take our jobs, and we have studied so many years, and it's not fair that, but it's not that. Please listen to me. This is a teamwork. The idea is to put next to the community at primary health care, which is available in every country, some services that can be externalized. No, I'm not talking about a surgery, for example, but testing, screening, rehabilitation in some way, and the areas that doesn't require a tertiary level can be managed from this philosophy. And what is needed for that? Technical documents, for example, the document I showed you recently, the handbook for screening at school-age children, that's a technical document to guide the process. Training materials, I will show you in a few seconds what do we have at WHO. Specialist supervision. The specialists are key in this approach. First, they trained the primary healthcare workers. They supervise the quality and they address the complicated cases. So we need the specialists on board, and they can supervise using telemedicine, teleaudiology, what is happening on the field without the need to be there. If we learn something good from COVID, because it was very, very hard for everybody, but we learned something good, and that is telemedicine is very useful. So it's a way to provide access to care. These are other examples of training technical documents for task sharing. We have the primary ear and hearing care training manual, and in that one you will find training on otoscopy, ear wash, and other basic procedures that can be done for a trained non-specialist. And on the right, this is the hearing aid service delivery approaches for low and middle income settings. With this one, you can go from assessment to fitting a hearing aid at community level. Of course, it's a specific group. As I said, everything is very clear on terms of the limits, but it's very, very, very useful, and it works, believe me, very well. We also have the Learning on Tap platform. This is a support resource. We have supporting courses. This is open access and for free, and it's a blended learning. You can do part of it online, and then you will need, of course, in-person training from a specialist to be able to be prepared to provide the services. And the idea is to use these courses together with the implementation handbooks you saw before. Here you will find the hearing aid service delivery approaches, and you will find the school-age children screening handbook training courses. They are very basic in terms of easy language. You will find videos, you will find examples, and I invite you to explore actually. Let's go back to our public health approach. Okay, there are 2 points that I want to address more in detail today, and that's the timely treatment and the hearing rehabilitation. I'm an otologist, and during my fellowship, the concept was, first of all, you treat otitis media, you treat the cholesteatoma, and when you finish with that, you go with hearing rehabilitation. But if we are going to provide a person-centered approach, we need to do it at the same time, looking for an holistic health approach. It's not like I wait 2 or 3 years until I decide on my patient with 3 surgeries for a cholesteatoma, let's say, to put a device for better quality of life and better hearing. It's in parallel. So it looks like a win-win, the treatment and the rehabilitation at the same time. But, and there is a very important but here, it's not to put a device on top of an otitis media that is not treated. It's to do both at the same time, mindfully. So how can we prevent on that? And the way to do it is with global accepted guidelines. That means everybody is doing the same with the same timing. This is the kind of things we do very well at WHO. And in that way, the diagnostic pathways of everybody will be the same. The times will be standardized. This is important for otitis media. The minimum criteria for treatment, as I said, the stepwise management, the follow-up, the use of hearing devices, when is appropriate and when is inappropriate, equitable care, strengths in coordination, improve long-term outcomes. And last but not least, if we all follow the same structure, it's easy to compare results and do research with strong numbers and strong results. Okay, so said that, thank you very much. Happy to answer any question you have. And yeah, that's from my end.
Okay, I'll start off with a question, Carolina. I've been monitoring the global burden of disease stats over the years, and happy to say that when you look at the graphs, there has been a decrease from almost all of Africa and the Indian subcontinent to a few countries. What are your statistics now in terms of hearing health, in particular, the deployment of your diagnostic ear or stats for cochlear implants and hearing aids in specific countries in Africa and the Indian subcontinent?
Okay, so let's go because there are different things. First of all, what I mentioned during the presentation is a recent review we did only for school-age children. As I said,
Okay.
when we plan on the topic of Working Day, it's always a evidence-based one. So we went to the GVD and looked for the prevalence in that group. And as I said, is 40% of hearing loss is due to otitis media in that group, based on that review. About here, who we are, sorry, this is very recent, and I must say, lots of groups are very interesting in implementing this app as a way to provide screening. We decided on that because when we start the discussion about screening, the discussion always stops with no, the equipment is expensive, we need a specialist, with that money we can do other things. So we looked for a way to eliminate that barrier. And we already, I think we already did for the group from 5 years and older. It's starting. We have a group in China, a group in Nepal, a group in India, different universities, NGOs that are starting to do it. From now, we have the clinical trials, so no really population statistic at the moment, but hopefully we will have that very soon. And you ask something else. I don't know if I'm answering everything or there is something I missed.
Yeah, I mentioned CIs and hearing aids because
Ah,
usually if you have a
yes,
good uptick of use of those, then
yes.
eventually the ones that are for otitis media also get taken up. So,
Not data related directly to otitis media, but in the work report on hearing, we looked for this gap I mentioned, about 80%. And the indicator we used for that gap was the access to hearing aid, you know?
mhm,
So
yes.
you can, it's reasonable to think, it's right to think the access to hearing aids is less than 20% for people. And we didn't do it for cochlear implants, but I guess it's even less, huh? Even less. So yeah, that's the numbers we have. Actually, and this is a teaser, we are starting to work in a situation analysis, and that is to update the numbers of the World Report on Hearing. The World Report on Hearing, there are things that are forever, strategies, scale up, programs, and so on. There's no change there so far. But the numbers, yes, the numbers changed. And the data of the World Report on Hearing is from 2020. So we need to update, and we are working on that. And since everything changed sometime, this time, of course, we are going to consider cochlear implants as a part of the numbers we want to have. Huh?
Great. And then last question, since we have a minute or so. Um, Sometimes it really depends on the communities who their point person is in terms of hearing care. I think in some countries they use school nurses or teachers for school age children. Well, I wouldn't rely too much on school teachers. They have their own sets of problems, especially at this time. But school nurses might be a good target. Are there specific examples when that actually works for communities or countries, even?
Yes, we have nurses for sure. First of all, to say our tools are meant to be tailored to the culture and the country and the region and the people and the needs of that community. Yeah? So no harm in change, whatever you need to change, and we are always open to support that adaptation if needed. About nurses, there are many examples. For example, in Western Pacific countries, it's going to be implemented a program for school screening, and there the main let's say professional or profile of the people that is going to provide the screening will be nurses at school. Teachers are super busy, but with the tools I showed you, they can perfectly do it after training, of course. And who else is super friendly, I would say. One of the things that we are waiting for, well, we have this populational survey named STEPS, that's the acronym. Basically, this is a non-communicable diseases survey, but it's not just the survey, also tests going with the questions. And there are optional modules in vision and hearing, and we got to put the hearing module in Egypt. So we have 21K tests already done there in adults. So I'm looking forward, I'm eager to see that
Yeah.
results. And I don't have that yet, but that will be for sure very, very powerful. Mhm.
All right. Really exciting. Uh, I don't see any new questions in the chat. Um, But maybe if you stick around, or we'll forward the questions to Carolina, we'll move on to the next speaker if there are no other questions. All right. Thank you so much, Carolina. I will now introduce Mirko Alde. Mirko is one of our COMMeND mentees from year 2, and he is a medical doctor specialized in audiology and phoniatrics at the University of Milan, and I hope I say this correct. Fondazione IRCCS Cagranda Ospedale Maggiore Policlinico in Milan. His clinical practice and research focus is on pediatric hearing disorders, with particular interest in otitis media and its impact on hearing and vestibular function. So his presentation will provide the basics of hearing loss associated with otitis media, analyzing the mechanisms underlying each type of otitis media. Please go ahead and share your slides, Mirko. We're looking forward to your talk.
Okay. Thank you very much for inviting me. I'm truly honored to be part of this webinar. I will discuss the fundamentals of hearing loss in otitis media, moving from pathophysiology to diagnosing principle. I am a medical doctor and researcher specialized in audiology and phoniatrics, and my clinical research activity is largely devoted to children with hearing imbalance disorders, with a particular focus on otitis media. I work closely with my mentor, Professor Paola Marchisio, who introduced me to the XII, for which I remain deeply grateful. In this slide, on the upper left, you can see my hospital, and on the lower left, my university, both located in the center of Milan. On the upper right, you can see the waiting area of the pediatric otology clinic, and on the lower right, the clinic walls, which are covered with drawings made by our young patients. This is our outpatient clinic with the automicroscope we use to examine children's ears. And in this slide, you can see some of the strategies we use to make the visit more comfortable for children. In particular, we have those with hearing devices, reward stickers, and coloring sheets that we update all the time. Otherwise, the children immediately start telling us off. So let's start with otitis media with diffusion. Otitis media with diffusion is characterized by middle ear effusion without signs and symptoms of acute infection. It can be recurrent or chronic and affect hearing, speech and language development, and vestibular function, negatively impacting quality of life. Notably, it represents the most common cause of hearing impairment in children. In 2023, we conducted a study on 375 children aged 2 to 6 years with a diagnosis of isolated speech and language delay, who were referred to our tertiary level audiology center. At hearing assessment, 35.5% of these children were found to have hearing loss. Most of them conductive hearing loss due to chronic otitis media with diffusion. The process leading to otitis media begins in the nasopharynx, where a viral upper respiratory tract infection inflames the mucosal lining and extends to the eustachian tube, narrowing its lumen and impairing middle ear ventilation. This causes tympanic membrane retraction and fluid accumulation, resulting in otitis media with diffusion. If bacterial pathogens subsequently invade and proliferate within this fluid, an inflammatory response develops and may progress to acute otitis media. During the COVID-19 lockdown, the reduction in circulation of respiratory viruses due to social distances measures resulted in a drastic decrease in the prevalence of otitis media with diffusion at our hospital, dropping from 40.6% in May-June 2019 to just 2.3% in May-June 2020. This reduction in otitis media with diffusion was clearly evident in both males and females, with the same downward trend observed across all age groups. In another study, we demonstrated that the prevalence of otitis media with diffusion assessed 2 and 3 years after the COVID-19 lockdown among children attending our hospital has returned to pre-lockdown levels. Automicroscopic examinations usually reveals a cloudy and yellowish tympanic membrane, often accompanied by hair fluid level, as shown in the left figure. A subgroup of otitis media with diffusion presents with highly viscous fluid termed gluear, as illustrated in the right figure. So let's take a closer look at the mechanical and acoustic consequences of middle ear effusion. Eustachian tube dysfunction leads to progressive negative middle ear pressure, and effusion replaces air within the middle ear cleft. Middle ear effusion increases impedance through increased stiffness due to reduced tympanic membrane compliance, increased mass due to fluid mass loading, and increased resistance due to viscous damping. Let me take a moment to focus on tympanometry. Tympanometry is a quick, non-invasive test that evaluates middle ear pressure and tympanic membrane mobility. Specifically, it estimates the equivalent ear canal volume, defined as the amount of air in front of the probe, normally 0.3 to 0.9 millimeters in children. Moreover, in a normal hair-filled middle ear with equal pressure on both sides of the tympanic membrane, the peak pressure of the tympanogram is 0 decapascals. A low equivalent volume may indicate the probe is pressed against the canal wall, for example, a stenotic external auditory canal, or because cerumen infection. A high equivalent volume suggests a perforation or a patent tympanostomy tube. Okay, on the left, we can see early eustachian tube dysfunction, characterized by mild negative middle ear pressure, typically with a tympanometric peak between minus 100 and minus 199 decapascals, corresponding to type C1 tympanogram, a mild tympanic membrane retraction. As this function becomes more significant, the negative pressure increases to less than minus 200 decapascals, producing a type C2 tympanogram and more pronounced membrane retraction. Finally, when middle ear effusion develops, the tympanogram shows no discernible peak, the classic type B tympanogram, and automicroscopy reveals a bulging yellowish tympanic membrane. This graph illustrates the progressive shift in middle ear compliance as eustachian tube dysfunction evolves, ranging from tympanogram, characterized by normal ear pressure and maximal compliance, to type B tympanogram, showing a flat curve. In addition to tympanometry, there are other basic cardiological tests that can be useful in the diagnosis of otitis media with diffusion. Acoustic reflexes are often absent or elevated, reflecting a mechanical conductive problem. Similarly, otoacoustic emission are usually absent or markedly reduced, not because of how their hair cell damage, but simply because the fluid attenuates sound transmission in both directions. Auditory brainstem responses can also help confer the conductive nature of the hearing loss, especially in younger children. With hair conduction ABR, we typically observe delayed absolute latencies, but normal interpeak latencies, because the middle ear effusion attenuates the stimulus. However, when we switch to bone conduction ABR, the absolute latencies normalize because the stimulus bypasses the middle ear. This air-bone gap on ABR is characteristic of a conductive pathology such as otitis media with diffusion. In older children, conventional pleural tone audiometry can be used to measure hearing threshold across different frequencies. Okay, now let's focus on pure tone audiometry findings in otitis media with diffusion. At the beginning, when the middle ear effusion is still minimal, stiffness is the dominant mechanical factor. This selectively impairs low frequency transmission, resulting in a rising audiometric configuration with mild to moderate conductive hearing loss and air-bone gap of about 20 to 30 decibels. As the condition progresses, mass loading and viscous damping become prominent. Consequently, sound transmission is affected across the entire frequency spectrum, and the audiometric curve typically flattens. In these cases, the conductive hearing loss may reach 30 to 50 decibels. This slide shows the audiological findings of a 6-year-old boy with bilateral middle ear dysfunction at different stages. His audiogram reveals a mild low frequencies conductive hearing loss, slight worse on the left side. The right ear presents a type C2 tympanogram indicating advanced eustachian tube dysfunction, while the left ear shows a type B tympanogram consistent with early otitis media with effusion. Okay, this slide presents the case of a 7-year-old boy. Automicroscopy revealed serous effusion in the right ear and a glue ear on the left. The audiogram demonstrated bilateral conductive hearing loss, more pronounced on the left side, while tympanometry showed type B curves in both ears, confirming middle ear effusion. In this table, I summarized the main characteristics of the different stages of middle ear dysfunction progression. Now let's turn to acute otitis media. Acute otitis media is an acute affection of the middle ear characterized by bright red and bulging tympanic membrane. However, the presence of otorrhea from a recent spontaneous tympanic membrane perforation is sufficient alone to confirm the diagnosis. Eustachian tube dysfunction leads to negative middle ear pressure and fluid accumulation that becomes purulent due to bacterial colonization. Consequently, ossicular mobility decreases, producing a type B tympanogram and a conductive hearing loss of about 20 to 50 decibel with a flat audiogram. This slide shows the audiogram of a 7-year-old girl with bilateral acute otitis media. Both ears present mild conductive hearing loss with hair-bone gaps across all frequencies. Automicroscopy revealed a bulging and hyperemic tympanic membrane on the left side, while the right ear shows otorrhea through an anterior perforation. Here we see two clinical examples of acute otitis media. The left image shows a bulging hyperemic tympanic membrane. The right image illustrates an anterior perforation through which middle ear fluid can be observed. Okay, so let's continue with recurrent acute otitis media. Recurrent acute otitis media is defined as 3 or more episodes of acute otitis media within a 6-month period, or 4 or more episodes within the previous 12 months, with at least 1 episode occurring the 6th month. Recently, we conducted a study of 141 children to evaluate the prevalence of automicroscopic and audiometric alteration at least 5 years after the diagnosis of recurrent acute otitis media. Hearing evaluation revealed that only 4.3% of children had mild conductive hearing loss, while high-frequency sensory neural hearing loss was observed in 19.9% of children. Notably, 24.8% of children show a sensory neural notch at 6 kHz. The 6 kHz region corresponds to a vulnerable segment of the basal cochlear turn characterized by high metabolic activity, oxidative stress, and microvascular compromise. In children with recurrent acute otitis media, the 6 kHz notch may therefore represent an early audiometric marker of subclinical cochlear stress in the absence of overt acoustic trauma. The most common automicroscopic alterations were localized meringosclerosis in 22.3% of cases, followed by extensive tympanic membrane retraction and retraction pockets. In particular, the total number of acute otitis media episodes since birth was associated with long-term high-frequency sensorineural hearing loss, and children with a history of spontaneous tympanic membrane perforation had higher prevalence of retraction pockets. We also conducted a study to evaluate the long-term effect of recurrent acute otitis media on balance and vestibular function in 55 pediatric patients. Children with a history of recurrent acute otitis media demonstrated significantly higher mean sway area values compared to healthy children for all four static posterography conditions. In particular, the present table reveals that children with more than 8 episodes of acute otitis media have significantly higher mean sway area values. At this point, we can move forward to chronic suppurative otitis media. Chronic suppurative otitis media is a long-standing inflammatory condition affecting the middle ear, characterized by perforated tympanic membrane that fails to heal spontaneously. It can be also classified as cholesteatomatous or non-cholesteatomatous, depending on the presence or absence of cholesteatoma, respectively. This is the case of a 10-year-old girl with chronic suppurative otitis media and the perforation involving the anteroinferior quadrant in the left tympanic membrane. Her audiogram shows a mild low frequency conductive hearing loss in the left ear. This is an example of an anteroinferior tympanic membrane perforation in a patient with chronic suppurative otitis media of the left ear. This is a 6-year-old girl with a perforation involving a posterior quadrant of the tympanic membrane in the left ear. Her audiogram shows moderate conductive hearing loss in the left ear. This slide shows a posterior tympanic membrane perforation of the left ear in a patient with chronic suppurative otitis media. This is the audiogram of a 6-year-old boy with subtotal perforation of the left tympanic membrane, showing mild to moderate conductive hearing loss across all frequencies. In this slide, we can appreciate a subtotal perforation of the tympanic membrane. This slide demonstrated that an audiogram alone cannot reliably distinguish between otitis media with effusion, acute otitis media, and chronic suppurative otitis media. If you look at the left ear across these three audiograms, the pattern appears similar. However, each child has different underlying conditions. Therefore, audiometric findings must always be interpreted together with automicroscopy and tympanometry to reach an accurate diagnosis. Cholesteatoma is an abnormal accumulation of keratinized squamous epithelium and debris in the middle ear. It can be present from birth as a result of residual embryonic ectodermal tissue. This is what we call congenital cholesteatoma. Conversely, acquired cholesteatomas can arise from an epitympanic retraction pocket. These correspond to a primary acquired cholesteatoma, or from a perforated tympanic membrane, which defines secondary acquired cholesteatoma. In this slide, we can appreciate a small pearl-like white mass behind an intact right tympanic membrane, consistent with congenital cholesteatoma. This is the audiogram of a 10-year-old girl with a diagnosis of congenital cholesteatoma in the right ear. It shows A mild to moderate conductive hearing loss in defective ear, more pronounced at low and middle frequencies. This slide illustrates the pathogenesis of primary acquired cholesteatoma. It all begins with eustachian tube dysfunction, which causes selective hypoventilation in the hepatic region. As a result, the pars flaccida retracts into the epitympano, forming a retraction pocket. Over time, keratin accumulates within the pocket, leading to the development of an epithelial-lined cyst. The lesion can progressively enlarge and cause bone erosion of the surrounding structures. This is an example of epitympanic retraction pocket. These slides show the stepwise evolution of a primary acquired cholesteatoma, beginning with an epitympanic retraction pocket and progressing to an expanding lesion. This audiogram belongs to a 9-year-old boy presenting bilateral chronic otitis media. The left ear is characterized by chronic suppurative otitis media with subtotal perforation and show a mild to moderate conductive hearing loss. On the right side, affected by a primary acquired cholesteatoma, we observe a moderate to severe conductive hearing loss with airborne gaps of around 40 to 60 decibel across frequencies. This diagram summarizes the pathogenesis of secondary acquired cholesteatoma. It begins with the marginal perforation of the tympanic membrane, which allows migration of squamous epithelium from the external auditory canal into the middle ear, leading to the formation of the cholesteatoma. Over time, the lesion progressively grows and causes bone erosion of nearby structures. Here, we see an example of a secondary acquired cholesteatoma. This audiogram belongs to a 6-year-old girl with a secondary acquired cholesteatoma in the left ear. It shows a moderate conductive hearing loss characterized by marked airborne gap across all frequencies. This audiogram illustrates the hearing profile of a 12-year-old girl with Down syndrome. In the right ear, previously treated with closed tympanoplasty, we observe a recurrent cholesteatoma with 50 to 60 decibel airborne gap across all frequencies. In the left ear, affected by a primary acquired cholesteatoma, threshold are slightly better, with an airborne gap in the 30 to 30 decibel range. This slide shows the progressive increase in conductive hearing loss across the different forms of chronic otitis media. In simple tympanic membrane perforation, hearing loss depends on the size and location of the defect. Anterior perforation usually causes only mild hearing loss, while posterior perforation produces a greater deficit due to the loss of the round window baffle effect without off-phase stimulation of the round and oval windows, causing phase cancellation and reducing the transcochlear pressure gradient. With progression to a subtotal perforation, the conductive deficit becomes more pronounced. In secondary acquired cholesteatoma, chronic inflammation promotes osteolytic activity through cytokine-mediated bone resorption. And finally, primary acquired cholesteatoma is frequently associated with more advanced ossicular destruction. In conclusion, I would like to leave you with one key message. Automicroscopy can help us anticipate the audiometric findings, but the audiogram alone cannot tell us the underlying pathology. Indeed, similar conductive hearing loss patterns may occur in different forms of otitis media, highlighting the importance of integrating audiological findings with a clinical examination. Okay, thank you very much for your attention.
Fantastic overview, Mirko. Thank you so much. I'll go ahead
Thank
and
you.
read Professor Peter Steiger's question from the chat. How does the otoscopist differentiate between a bulging eardrum from a retracted eardrum in a typically 2D image?
Yes, it's not simple, but in our hospital we use automicroscopy, so it's simple to differentiate between bulging tympanic membrane from retracting tympanic membrane. But it is important to have experience because at the beginning it is not simple, but it is useful to integrate. The automicroscope examination with hearing test and tympanogram, especially at the beginnings, because gives us more information, especially for is not experienced in this type of diagnosis. But when you see many children every day, you understand the difference between retraction and bulging tympanic membrane with automicroscope.
I saw Peter's thumbs up. Are you satisfied with the answer, Peter, or do you have a follow-up question?
Yeah, I am. Thank you, Reggie, and thank you, Marco. It's yeah, looking at 2D images can make it very difficult to see the difference between concave and convex structures. So it may be the way that the light shines on the curvatures that might help, but for the uninitiated, it can be very tricky. So I like the point about the experience to differentiate between the two. So thank you for that.
Thank you. Yes, when cholesteatoma is suspected or inserting, sometimes we perform COMMeND CT scan, so we have the certain to have the correct diagnosis before surgery.
Thank you.
Thank you.
Thank you. We also have a comment from Dr. David Malter on pneumatic otoscopy. Do you want to elaborate, Dr. Malter, on your question or your comment? And then we'll go to
Just
Gabby.
when you're faced with a decision about whether the drum is coming towards you or moving away from you, if you use pneumatic otoscopy and you apply negative pressure, that will move a retracted drum towards you, but won't change a bulging drum. And similarly, if you add positive pressure to a bulging drum, it'll have a tendency to push the drum back. So pneumatic otoscopy helps you determine whether the drum is pushed toward you or pushed away from you.
Very cool. Thank you.
Thank you.
Gabby has a question or comment.
Yeah, great talk, Marco. That is going to lead beautifully into my talk. So thank you. You did a lot of great background for me. I'm curious about that 6K notch that you see in some of the audiograms in your, I think that was the longitudinal study and the follow-up. Do you know if those kids, by and large, had tubes placed or had surgery? Like, could that potentially be a noise, response to surgical trauma? It's so hard. I'm so curious about that sensory neural or what looks sensory neural, right? We don't have bone conduction at 6K, so I guess we don't really know, but.
Yes, it's very curious, but we excluded all children with risk factors for hearing loss, including the noise exposure. And we found this 6 hertz notch. It's very curious, but a possible explanation is that it's a very vulnerable region. Maybe many episodes of acute otitis media can affect this region and leaves this type of notch.
Mirko, I just want to say I really appreciate the details in your talk. I'm so glad that that's recorded so that our mentees can also use that as a reference. That includes current and future mentees. We are keeping our archive and then promoting it to our new mentees so they can just go back to previous talks.
Thank you very much for this opportunity.
Yes, thank you. So I'll introduce Gabby. Dr. Gabrielle Merchant is an audiologist and hearing scientist and the director of the Translational Auditory Physiology and Perception Laboratory at Boys Town National Research Hospital. It's a TAP lab. She earned her BA from Smith College, her PhD from the Harvard MIT Speech and Hearing Bioscience and Technology program, and her AUD from the University of Massachusetts Amherst. Her translational hearing research focuses on auditory mechanics, auditory perception, and advancing evidence-based practice through improved clinical diagnostic tools. So happy to have Gabby as a COMMeND mentor and always learning from her whenever she talks about cutting edge research in audiology for otitis media, paving the way. Gabby, thank you.
Thank you so much, Reggie. Thank you for organizing this great session and for all your leadership in the COMMeND network. It's a wonderful program I feel very fortunate to be a very small part of. So as I mentioned a second ago, Mirko gave a beautiful talk that introduced a lot of what I'm thinking about and sort of what led into this work. So it makes a really great introduction, but I'm excited to have an opportunity to share some of our work from my lab on using wideband tympanometry to advance diagnostics for otitis media diagnosis in children. So this work, I'm a clinical audiologist, I'm not an otologist. And so as I was a student actually training on an pediatric ENT clinic. And so as an audiologist, I'm really curious about the hearing loss and sort of figuring out some information about what's going on that will help usually the physician decide how to manage a child who has fluid. And so on this clinic one morning, we saw 3 kids back to back, and that sort of the series of them gave me some pause. So this first kiddo comes in, I look in their ear, and unlike an expert looking under otomicroscopy, I'm just looking if there's any, obvious drainage, cerumen that would prohibit me from putting a probe tip in or something. And I looked down and everything looked relatively healthy and typical, grossly normal. So we moved on and did tympanometry. And then this first child, who was about 4 years old, flat tymp, and then they conditioned really beautifully to behavioral audiometric techniques. And so we got some good information about their hearing in the booth. And this child had sort of that moderate, mild to moderate conductive hearing loss that we often see with otitis media with effusion. Second kiddo came in, was a little bit younger, about 30 months of age. Same presentation, essentially, grossly normal otoscopy, flat tympanogram, did not condition quite as well to our behavioral testing and sort of tapped out a bit quicker than the first kiddo. But the information we did get from air conduction on this child suggested that they had normal to near normal hearing. So I remember looking at my preceptor that day and saying, well, why does this child have pretty good hearing and the kiddo we just saw has all this hearing loss? And she was kind of like, oh, it's all over the place with OMI. And I was like, oh. And then a 20-month-old came in. And I swear the terrible twos is more of a audiology sort of term because 2-year-olds are just really challenging to test behaviorally. But same presentation, grossly normal otoscopy, flat tymp, and we just could not get this child to condition to any behavioral audiometric techniques in the booth. So we had no sort of behavioral hearing information on them. And after seeing these last 2 patients, I realized that we can't really assume how this child is hearing just based on a tympanogram because it does seem to be quite variable. So I started digging into the literature and getting curious about why can you have this sort of similar presentation with a flat tymp and grossly normal otoscopy, but highly variable hearing loss. And though this had been well documented in the literature, a range of hearing loss from 0 to 50 dB in ears with otitis media with effusion, we did not yet have a full comprehensive grasp about what about the underlying mechanics and sort of individual characteristics of a given case of OME would cause this variability. And so that's what my lab in part has been really digging into in these last several years. And so for the sake of time, I can't go into sort of all of the details, but I wanted to sort of give you an overview of some of what we are learning. So most of the data I'm going to share today are from children that we've recruited from our ENT clinic. So these are primarily children with otitis media with effusion, as opposed to we mostly see acute otitis media in our pediatric clinics. And most of these kids have OME. They're on average about 34 months of age. We will see any pediatric participant or patient, but because of the sort of peak age range of where OME is most common, the age skews pretty young. These children are diagnosed in our clinics at Boys Town by an ENT as having OME, and we recruit them into our study. And then we wait to see them in the lab until usually the day before surgery, if possible. At most, it's 2 days before surgery, but the vast majority of these kids were seen usually even the night before their morning surgery the next morning. And they come in for about 2 hours and do this very comprehensive audiologic battery where we do behavioral audiometry, and we have every sort of advantage in the lab. We can take breaks, and we have 2 testers, and we try to get as much information as possible that way. But we also do several objective measurements: otoscopy, videotoscopy, standard tympanometry, wideband tympanometry, and otoacoustic emissions. We do have an age-matched cohort of children who have no recent documented history of OM in the last 12 months. And though I am very interested in children with sensory neural hearing loss who have co-occurring sort of transient conductive hearing loss from OME, for this study, we kept it sort of to keep it clean. We excluded children with sensory neural hearing loss. And so that was at some point in their monitoring protocol, we confirmed that their bone conduction thresholds were normal and there were no signs of sensory neural hearing loss. So these are purely conductive losses. So I'm going to assume some familiarity with several of the tests we do, especially given the last talk: the audiometry, the standard tympanometry, which was beautifully described. But the one tool that you may be a little less familiar with is something called wideband tympanometry. And this is very similar to standard tympanometry in that it's a measure of sort of those peripheral auditory mechanics, but it differs in the stimulus primarily that we use. So instead of using usually a 226 hertz sine wave, which tells us a lot about sort of the low frequency stiffness effects of the system, it uses a clicker or chirp, which gives you information across a broad range of frequencies, usually around 200 hertz to around 8,000 hertz. And so you get information not just about stiffness, but about mass, resonance, etc. So we sort of think of it as a more comprehensive measurement of middle ear mechanics. It's FDA approved. There are now multiple sort of common clinical devices that this is built into. And we are looking at we play a sound and look at what's reflected back. So there's some different transformations of this you can look at, but the one that's most commonly looked at right now in clinic is something called absorbance, which is really the percentage of sound that is absorbed by the ear at each of the frequencies from that click or that chirp. And you can do these measurements pressurized, much like you do a pressurized tympanogram. And you can look at things like the response at TPP versus the response near 0 decapascals or ambient pressure. But you can also just do these measurements at ambient pressure, which can be advantageous in some cases. Very little tiny newborn ear canals where their ear canals are very compliant, or in a post-surgical ear if there are concerns for pressurizing. Sometimes if people have a large perforation or a patent tube, it can be hard to get a seal for a standard tympanogram. So you can still get information about the mechanics using an ambient measurement where you don't pressurize, which is kind of nice. Okay, so we recruit all these kids. They come in and do this comprehensive battery in the lab, and then we see them in the pre-op room right before they go back to surgery, the morning of surgery. I would do standard TIMS, DPOAEs, and usually wideband tympanometry that morning. Very quickly, we can't do repeat behavioral and pre-op, unfortunately. We just don't have the time or resources to do that. But that confirms that their middle ear status has not significantly changed from when we saw them in the lab to right before they had surgery. And then they get brought back to surgery, and we have done a lot of things during surgery to both qualitatively and quantitatively characterize various features of that given episode. So we look very closely at what their eardrum looks like, and if it looks very inflamed and red and bulging or retracted. We try to qualitatively assess how full the ear is of fluid. So the surgeon usually takes a very good look under otomicroscopy after cleaning the ear out. If there's any air bubbles, air fluid line, any signs of air. He also would qualify whether the effusion looked mucoid or serous, or perhaps purulent. And then we were also collecting for a while samples of those effusions to both quantify the volume of the effusion and the viscosity of the effusion by pushing that effusion through a microviscometer. And the short version of a long story is that of all of those things that we have looked at thus far, at least when it comes to the hearing loss, the only really variable that stood out as interesting was actually that qualitative assessment of how full the ear was of fluid. And that is it completely full? There are no air bubbles, no signs of air. Is it partially full, which means there's either air bubbles and air fluid line, and that can be pretty variable in terms of how full it is. Is it clear? In about 30% of cases, we find that by the time these kids got to surgery, their ear had spontaneously cleared. There's no measurable fluid at that point. So those are sort of the volume groups that ended up being meaningful. And what we found is when we look at the hearing loss and we separate these children by how much fluid is in their ear, you can see it's those children with ears completely full of fluid that have that sort of moderate conductive hearing loss that we often see. And if there's any air in the middle ear space, even a bubble or two, sound transmission is highly resilient. Like it seems to be able to still quite a lot get through. And so you see sort of normal to near normal thresholds in those partial effusions. In fact, they're not as a group statistically different than ears that are clear of effusion at the time of tube placement. So there's no measurable fluid, though both of those groups are hearing poorer, statistically speaking, than their age-matched normal peers. And so that was also an important distinction as to why we kept those ears called clear and empty as opposed to normal, because clearly there's something still going on. So there's no measurable fluid, but I suspect there's residual inflammation in that system. Maybe there is fluid still in the mastoid air cell space, things like that. So I don't think it's fair to call them normal. And I think this sort of supports that idea too. But viscosity did not seem to drive hearing loss. None of the other factors that we sort of assess seem to drive hearing loss, but this volume of effusion very consistently seems to drive how much hearing loss there is. And there are some temporal bone data from Mike Ravitz at Mass Eye and Ear that he saw a similar effect in a temporal bone model. So this sort of supports that. So we said to ourselves, well, that's interesting, at least as an audiologist interested in the hearing loss. Is there anything in our toolbox when perhaps we can't get those behavioral data that could help us know something about how full the ear is? And so the first measure we thought to look at was our tried and true standard tympanometry. And so when we look at all the kids who have partial effusions versus full effusions, the take home here is that standard tympanometry does not significantly differ between these two groups. So it looks pretty much identical in most cases. Most of the ears with partial effusions have flat type B tympanograms. And so this is just one example of a child who on his right ear had a partial effusion and on his left ear had a full effusion of similar viscosity and otherwise similar characteristics. And you can see his tympanograms don't differ. So then when we looked at the wideband tympanometry, I'm just going to walk you through what these plots look like because I think they're probably a bit unfamiliar to many of you. But instead of looking at pressure along the x-axis, here we're looking at frequency. So we're going from low frequencies to mid to high frequencies. And I don't know if you can see my mouse. I'll put the laser pointer around just in case. And then the absorbance value goes from 0 to 1. 0 meaning nothing was absorbed at that frequency, 1 meaning everything was absorbed by the ear at that frequency. And so these are all individual absorbance tracings from kids in this study. And the first thing that this should highlight to you is that it's kind of all over the map. You might look at this and be like, well, this isn't useful. It's all over the place. But that's what's really exciting about it, is that it's actually, this highlights how much variability there is in terms of what's mechanically happening in the system in these ears. And I think that that's meaningful variability. And so if we take this full group of kids and separate it by which group they are in terms of that effusion volume, these are the group averages that you see on the right here. So these full ears have very low absorbance across the board. Partial ears have better absorbance across frequency. Clear ears, even better absorbance. Then you can see the normal control ears. So basically, you see that absorbance decrease as the amount of fluid in the middle ear increases, and in turn, as the hearing loss increases. And though this is, and this is just the example of that same child that I showed you earlier, who had the partial effusion in the right ear and the full effusion in the left ear. And though his tympanograms look identical, you can see below what his wideband absorbance tracings look like and how different they are. So sort of that larger area under the curve for the partial effusion as opposed to the full effusion. So while you don't get that distinction with standard tympanometry, you do with wideband tympanometry. And we actually, as a clinician, I'm really interested not just sort of on group level data. I actually don't love even looking at group level data. I want to know if I see an individual kiddo come into clinic, can this tell me anything meaningful? And so what we did is we took all the kids in the study and all the data and trained a machine learning algorithm. We said, here's 70% of the data. This is what a full effusion looks like. This is what a partial effusion looks like. This is a clear ear. This is a normal ear. And then we gave it 30% of the unseen data and said, tell us what these are. And it does, we did this in a few different ways, but the first comparison was just effusion present versus absent. So those full and partial ears were grouped together and the clear and normal ears were grouped together. And if you look at sort of the accuracy of standard tympanometry to say fluid present or absent, it's depending on the paper you look at 80-ish% accurate. And we got about a 95% accuracy in this case with wideband. So we are sort of getting more accuracy than standard tympanometry. We then, I'm really interested in that distinction between the full ears and the partial ears because of how differently they're hearing. And so that was the next comparison we made, and we get an accuracy of about 89%. So again, not completely perfect. There's always these like sort of borderline ears where we're like, there's one tiny air bubble and you can sort of see it. So that classification can be hard, but definitely still very good accuracy and sensitivity and specificity there. And then the clear versus normal ears are a little more challenging to distinguish because they are so similar mechanically. And so our accuracy is a bit lower there. And I don't know that that's as clinically meaningful of a question, but definitely something that we're still working to improve. So this actually came in handy when for me personally, this is my son Grayson, though it was several years ago, and I brought him in to be a research participant in a colleague's rotary chair study. She was collecting normative rotary chair data, and we wanted to make sure the kids had normal middle ear status, so TIMS were part of her protocol. And I bring my healthy, normal hearing, as so I think child in, and she runs TIMS on him, and she's like, "Hey, Gab, did you know his TIMS are flat?" And I was like, "Nope, sure didn't." Like, not only am I the mom audiologist who doesn't know her child has flat tips, but I'm like the mom audiologist that studies fluid in their ears. So I was like, how could I possibly have missed this? Which we see this all the time. And so, of course, I ran upstairs and made sure to get my tight in and run some wideband tips. And you can see that they have quite a lot of area under these curves. And so these were pretty well aerated ears, despite the flat tips. He was probably hearing pretty normally, which is perhaps why I had no idea that he had flat tips. So he still got an ENT visit out of the gig. But it was really interesting to see that measurement become suddenly useful to me in real life. So these data have been pretty exciting to us because, again, if I think back to that experience I had in clinic and that third child I saw, I had no idea how that child was hearing because testing children behaviorally in the age range where OME is most common can be really challenging. Sometimes we get very limited data. And so as much as we should be thinking about, and even our clinical guidelines in the US suggest that we should be thinking about hearing loss as a factor in decision making and sort of the management of these children, if you don't have the audiogram, then it's really hard to take that into consideration. And so the thought here is that, well, if I can't get an audiogram, could I make one of these wideband tympanogram measurements and sort of infer how a child is hearing? If it looks very full, they're probably not hearing very well, or sort of on that more mild to moderate conductive hearing loss end of the range, as opposed to if it's partially full or clear. And so a lot of this does rest on the idea that testing children behaviorally is challenging. I usually don't have to convince people who work with these kids of this very frequently, but we did want to quantify it. So we got some feedback on a grant application where people were like, "Oh, you can usually get it." And so we looked at kids who were coming into our clinics under the age of 5, who were there for sort of a tube consult. And in 20% of those kids, even at a tertiary specialty hospital, Boys Town has some of the best pediatric audiologists I've ever met. We get absolutely no audiometric information in 20% of those kids coming in for tube consults under the age of 5. And in an additional 50%, we're usually only getting something in the sound field. So this is not telling me about how their individual ears are hearing. And in a lot of cases, it's a single sound awareness threshold. So no frequency specific information. You can have a lot of hearing loss and still have a reasonably normal SAT in one ear. So we're usually only getting ear specific information on about a quarter of these kids. And even then, it's often not a full audiogram by any means. And so knowing how they're hearing in general is likely useful to, again, thinking about management. I'm particularly interested in that ear-specific information because especially if you look in the animal literature, if we think about downstream developmental impacts of recurrent OME over time, a lot of the concern rests on things like binaural processing and how the two ears work together. And we see tons of asymmetry in these kids. And I think Mirko gave several examples where you saw very asymmetric hearing losses in the two ears. And so as our brains are trying to build these binaural circuits, I think a lot about like what happens not when you just have hearing loss, but now you've got like fluctuating, potentially different hearing loss in the two ears. And I think that thinking about how both ears are hearing independently is probably going to be important as we try to understand that better. And in that same cohort of kids where we only got about 25% with ear-specific audiometric information, we get wideband in almost everyone. There's always one kiddo here and there who like will not let you anywhere near their ears. And that's, we probably could hold them very tightly and get it if we really wanted to. We try to make our testing not upset them too much, but we are able to get the wideband measurements in the vast majority of kids we see. And so we're currently trying to take this a step further. I think it's nice that we could look at one of these absorbance tracings and say, this looks full, they're probably not hearing well. But these are mechanical measurements, and this is a mechanical hearing loss, essentially. It's a loss of sound conduction somewhere because of a change in the mechanics. And so we wondered if we could sort of take even the effusion volume out of the equation. There probably is some smaller role of viscosity and inflammation and all sorts of other characteristics. And just say, what is this mechanical measurement telling us about predicting the hearing loss? And so as a very first pass at this, we took each of those individual absorbance tracings and averaged it across frequency down to one number. I never thought this would work, by the way. It was a very quick and dirty first pass, just playing with the data. And then we compared that to the average air bone gap in children where we had very good masked bone conduction threshold. So we had very accurate quantifications of their air bone gap. And so I averaged the air bone gap from at 500, 1,000, 2,000, and 4,000 in those kids. And I compared those two values, and was the result. And so it was a much stronger relationship than I anticipated. And we've done a lot of variations of this, and you can see we now have a computational model where we're trying to even further improve this. So for the sake of time, I won't go into all of that. But the sort of short version of the story is that there is a very strong relationship between these absorbance measurements and the conductive hearing loss in these children. And we are working to develop a wideband absorbance-based acoustic estimate of that conductive hearing loss within about 3 to 5 dB of their actual hearing loss, which would be pretty clinically significant. 5 dB is usually what we consider test-retest for behavioral audiometry. And so we are continuing that work, but feel very optimistic about being able to predict within that range. So our hope is that we will be able to develop sort of a tool that can be integrated with these clinical devices that uses the machine learning algorithms that we're developing. And, audiologists, a tech, someone working on an ENT clinic somewhere could make one of these measurements and they can see the tracing themselves, but the machine learning algorithm would also tell us, one, the estimated conductive hearing loss in that ear and something about the volume of the effusion as well. So more to come there, but that is what's in development right now. And with just the last couple of minutes, I wanted to share some additional ongoing work that we are doing relating to this. So everything you've seen up to this point is really about characterizing their hearing loss at a singular time point when they come into clinic, maybe for that pre-op evaluation. We're also interested, as I sort of alluded to, in some of those longitudinal long-term developmental effects and what's the influence of having repeated fluid over time. And are there kids at risk for sort of these longer term developmental impacts, and can we identify those kids in some way? And so in order to start to answer those questions, we have been longitudinally monitoring a cohort of children. And so these kids, same sort of profile, get identified primarily from ENT clinics. Some of them are going to have tubes placed. Some of them are watch and waits. We take them regardless of their management protocol, and we see them every week up until either they have surgery or the effusion resolves. And then if at either time point, whether the effusion resolves or they have surgery, we then monitor them for a year after that every month. And so we were able to do this. We could never get families to come into the lab every single week, we'd have a very small N. And so we were able to do this because we sort of take this van that you see pictured here and we bring it to these families' homes, and we can do pretty much all of our testing in the van. We've come up with methods to pretty much assess all of the tests that I described earlier in the van. There are some limitations in bone conduction because of the noise floor in the van. We're actually playing with some ideas to work around that, but we can still get it. And if we think if we have the bone conduction from the lab, it's probably not as essential because we're not suspecting bone conduction changes in these time periods. It's really about the air conduction changes that we're tracking. And so these are just two sort of case studies to give you a glimpse at some of the data we're able to get through this longitudinal monitoring, and also how wideband tympanometry changes over the course of these measurements. So this was a child who came in. This is her initial visit. Flat tympanograms, as you see, did not condition to behavioral audiometric testing. So we have no audiogram. Here's her absorbance tracings, but we did have otoacoustic emissions, which can be really useful, especially when we don't have behavioral audiometry. A lot of people don't do OAEs if there's a flat temp, and we find them really valuable, actually. And so this sort of combination of a few OAEs in both ears and sort of that partial effusion looking absorbance suggested this child obviously has fluid in their ear. The temps are normal, but it's probably hearing in that sort of borderline normal range because it's a partial effusion. We went back a week later and same kind of profile, flat tympanograms. Actually, her OAEs were better at this visit. So we see a few more OAEs present, suggesting maybe we're starting to move towards resolution. And the green tracings here you see on the absorbance graph are from the week before. So you see there's a little bit of improvement, a little bit higher absorbance in both ears. So despite the fact the tips are still very, very flat, there are some signs both in the OAEs and the wideband absorbance that we might be moving towards resolution. She was stable for about 3 weeks, looked very much like this. And then we went back for her visit right before she had surgery. And this is what it looked like. So again, flat-ish temps. The green tracings were again the week before. So you see now a reduction in the absorbance, and she no longer has any OAEs. So she is now a full effusion right before she goes into surgery. I actually think she got acute otitis media based on what the otoscopy looked like. So thankfully she had surgery. But you can see the temps are pretty stable. There's a lot of fluctuation, both obviously in the mechanics, which the wideband is highlighting, and her hearing, which the OAEs are highlighting. And this is just another child where we had a little bit more information. They did condition to behavioral audiometry, very asymmetric pattern between the two ears. And so flat tympanogram in the right ear, negative pressure in the left ear. You see a little bit of hearing loss, maybe borderline normal on that left ear, probably because of that negative pressure. And you see like 30s to 45s on that right ear. So sort of more of that mild to moderate conductive hearing loss, very low absorbance, no OAEs. So she's got a full effusion in the right ear, just negative pressure in the left ear. We go a week later, and we're really just monitoring the right ear at this point. The thresholds are better. Now we're at 25s and 20s. The temp still looks pretty atypical, and the absorbance has increased quite a bit, and we have a few OAEs present now. So again, moving towards resolution. Go back a week later, and interestingly enough, the hearing loss is now worse. So not as bad as it was the first visit, but we're going in the wrong direction. Still flat temp. The OAEs are gone. The absorbance is very low again. So just a lot of fluctuation in that ear. And again, I really just wanted to show these to highlight how much variability and fluctuation can occur even within these weak time points, but how sensitive the wideband appears to be to these changes that are consistent with what we see also in the OAEs and the hearing loss changes. So hopefully this has demonstrated that this wideband tympanogram measurement has a lot of clinical utility. It's very feasible to obtain even with very young children, infants, toddlers, that it is useful in predicting effusion volume and hearing status in children with OME, and may also be really useful to monitor fluctuations in hearing, which may both enhance clinical management and give us a tool to help monitor things if we are thinking about developmental outcomes as well. So just want to acknowledge the many, many people involved in this work. I have a really amazing team of research audiologists and an ENT, Rick Tempero, who I work very, very closely with. We recruit a lot from his clinic. And so he plays a big both clinical and scientific role in the project. Lots of research assistance, very generous funding from NIH, and happy to take questions.
Awesome, Gabby. That was really great. Congratulations on your funding, the new R01. Given the
Thank
current
you.
challenges, it's really remarkable. I'm really happy
Yeah, this
for
work
you.
was funded. The grant was terminated by DOGE a year into a 5-year R01, but we submitted a new version of it that just recently got funded. So it's been a journey with this work, but we're very grateful that we are now hopefully funded for a bit.
Well deserved. How is Y being taken up in different institutions? I hope that they actually use that as a pre-operative tool, whether or not to push through with ear tubes.
Yeah, so I have seen such a big shift in the use of wideband in clinic, I would say in the last 2 years. So we, about 2 years ago, worked with our audiology and ENT teams at Boys Town and rolled it out clinically here. And so now at Boys Town, wideband has become the standard. Originally, we just rolled it out for peds because the effects, as you saw, are quite large. But the clinicians quickly decided that they wanted to be doing it on everyone, which has been really great. So our audiologists are using it, our ENTs are interpreting it and using it. I think it's going to take a while for us to really understand how the surgeons are using it as part of their clinical decision making. I think they're still sort of just getting accustomed to looking at it and knowing what it means. So it's going to take a little while. As part of that process, we worked with those teams to develop resources, both for audiologists around the country would say, what do I write in my report? Like, how do I talk about this? Like simple things, but that made that translation just a little more challenging. How do I interpret it? And so as part of that process, the lab has been developing tools. And so we've been sharing those quite widely with other clinics around the country. And so I probably get an email at least once a month, if not weekly at this point, from a clinic somewhere that's like, we're going to start doing these measurements. Like, can you share some of these resources and help us get started? So I think, there's still a lot to do there with the translation, but I am seeing in real time it really start to get taken up, which is exciting.
Yeah. Tanya has a comment. You want to say something, Tanya? She says that you should start it in Brazil.
Hey, feel free to email me. I am always happy to help support that however I can.
Yeah, or anywhere in Latin America.
Yeah, that would be amazing. Well, thanks, guys. If anyone does have questions, people can always feel free to email me too.
Yeah, always a pleasure to have you, Gabby. Thanks.
Thanks, Reggie.
Now I'll introduce Anka. Anka, I always have a challenge saying your last name. So
It's
how do you say
Leichle.
Leichle? Okay, I
Yeah,
think that's a little
it's
bit
hard.
better.
It's hard to say. I know.
So Anka is professor and chair of the Department of Otorhinolaryngology at Hanover Medical School since January 2025. Congratulations for being chair. Not too many female chairs around the world, so I'm really proud of you, Anka. She worked before at the Department of Otorhinolaryngology, Head and Neck Surgery, University Lübeck in Germany, and did a research fellowship in otology at UCSD, University of California, San Diego, from 2006 to 2008 with Alan Ryan. Alan's here too. Her main interest is focused on the translational research of the pathogenic and immunological mechanisms of otitis media and in finding new treatments, especially for patients with chronic otitis media. Please feel free to share your slides now, Anka. She will be talking about rehabilitation options, including surgical options for otitis media today. And we're really happy to have you, Anka. Please go ahead.
Thank you. Can you see it?
Yes.
Okay. Thank you, Reggie. Thank you, everyone, for having me here. Yeah, I just got the position, and I want to let everyone know that most of the work I present today was done in Lübeck, where I had the great pleasure with a great team. Also, Susanna and Jonas are here as mentees. So thank you, everyone, for having me and working with me, and also Ellen, thank you. So we heard a lot, so I can go quickly through the point, but one thing is for sure, chronic otitis media is one of the diseases with a significantly high socioeconomic burden. We know all it's multifactorial, that's why it's so hard to treat, and that's why we all sit here for years because the treatment is not easy as we think, as we heard also from Carolina. And we have to look what's going on in different ways. We also have in the chronic parts, we do have pathogens which really keeps us very, very busy, such as Pseudomonas or Staph aureus or Proteus. And those patients, they encounter significant burdens, as we know. And of course, the hearing impairment is very bad, and they have a conductive or mixed hearing loss. We are talking about the hearing loss, and I have to have the pleasure to talk about rehabilitation, because we know these patients develop 50% develop an associated hearing loss, and treating the hearing loss can potentially reduce the global burden of those patients by 80% if we treat them properly. And the thing is, we need to decide what we do. And we can manage it through appropriate surgery and remove the local inflammation properly, for example, with a laser I'm going to tell you later. And if we go and do rehabilitation, as Carolina mentioned, it's very important that the local situation is inflammation-free, or in the case of cholesteatoma, totally cholesteatoma-free, so we can implant implantable hearing devices. And what we always have to keep in mind, we have these Pseudomonas, they are building biofilms. Even if we do surgery, it looks good. They might sit as the persister cells somewhere in between, and then they're fine. And once the patient is weaker or has an immune deficiency or something happens, we still don't know exactly when and why. The bacteria are growing and the middle ear infection is coming back. And this is very important to look at. And so it's very interesting and very important we look at the local bacterial colonization, and also to look what we did about the intestinal microbiome, because we find some associations. So in total, we have to have a conceptual treatment concept. We have to look at the autopathogens, at the immune response for pharmaceutical treatment, and of course that we can do safe surgical interventions and hearing restoration. We heard a wonderful talk from Mirko, so I don't need to say again everything. That's great, thank you. So I focus on the rehabilitation. So if we have chronic otitis media, we have all those leading symptoms, the otorrhea, hearing loss with acicular destruction, and it's low, but it can lead also to total destruction. And then we have a sensorineural or combined hearing loss, or we only have a bone conducting hearing loss. The final therapy is then a tympanoplasty hearing aid, or if it drains even more, we love to do an implantable hearing aid. In cholesteatoma, it must be operated. There's no way out. We can't wait. We all hope that there's some antibodies. We all hope we could find some genes. So far, we have to do surgery until the cholesteatoma is gone, and then we work the same path. We try to reconstruct the ossicles if possible. Most of the time, as you can see here, there might be no way to reconstruct it, and find wonderful tools to reconstruct the hearing, what I'm going to talk. You can see pictures of the OR in Lübeck. This is a patient with COM, or comma, as you say. You have here the middle ear, and then there was granulation tissue everywhere. And so we had to do a mastoidectomy and looking where the process is going. Luckily, we could keep the ear canal wall up. So this is going to be closed, and the patient is fine after the mastoid is drained in the middle ear. But still it looks big, and still it's a lot to do. And as you see, it's microscopic and endoscopic surgery and big ways to do the ear surgery. It's even worse when you have a cholesteatoma like this. You can see the middle ear. This is also from Lübeck. When you can see the middle ear with the cholesteatoma sac, you can look into the sac if you look properly, and then you can see the incus. Here, the incus going to the stapes, and here the cholesteatoma is going down, here back down to the mastoid. So we come from the back, looked again the same way as you saw before, mastoidectomy, and we saw, oh, the cholesteatoma sac is there. So we go and look if we can get it out. And we see here the middle fossa, so the bone to the middle fossa, to the brain, and it has to be get out everything. So we drilled, and here the cholesteatoma is like a carpet wall, wandering and walking and sitting in here, as you can see here. If you drill more, you detect more, and that's very dangerous because we heard from Mirko that it eats the bone and erosions the bone. And then these are the patients we see at night with a brain abscess, and we have to work with the neurosurgeon. They are draining the abscess, and we are draining the cholesteatoma from that side. So for sure, we need to get this out properly. That's when it gets really big, as you can see here. The canal wall is going down. You can see this was the middle ear before. This is the whole cavity. This is the sinus. This is the dura sinus angle. This was from the antrum. You can see here the facial nerve, and that's the rest of the stapes. And for sure, we have a problem to here. But before we can restore it, we have to wait and be sure that cholesteatoma is for sure gone. And that's the thing I'm going to talk and tell you how we can do this. First, we reconstruct that, wait 6 months, and then we redo and rehabilitate it with hearing aid. But we want to make sure, implantable hearing aid, that this is cholesteatoma free. And that is how I come to our project, what we worked on, also Susanna and Jonas. And what we did is we got funded for 3 years, and we looked endoscopic OCT laser diagnostics because we want to make the surgery smaller, and we want to have a diagnostic tool which detect the cholesteatoma and the middle ear inflammation in this chronic form, so that we are sure it's gone and we can go on and do surgery. So this is the implication. What we finally, I can't tell you everything because I think Susanna has probably talked about part of it, but this is the final step we used, or we have been able to to use in the OR. And this is like a coca arm. It's a robotic arm where we use the OCT. And this is the OCT part. And we use in surgery to intraoperative measure the part of the cholesteatoma or the inflammatory process. And then we can say we have everything out, or we still need to go on more surgery, or even, this is the final aim we want to do, put the inflammation out and implant in one setting. But we are not that far, but we're going to go there. This is the final plan. Because often patients are older, they don't want to have a second surgery. But this is the final goal. And so these are the first measurements. We finalized them this year, and we have been really happy to work with it in the OR. You can see my former boss, Professor Bruchhage, and me. And then we put it in there and got the points of where we say we do more surgery or we do less surgery. Like we have an intraoperative histology or pathology in the OR. And the other thing is we talked about rehabilitation and we talked about concepts. To do that, we love to do a laser. Hamilton from England was doing this a lot with cholesteatoma, and we widened it. We brought it away from also for chronic otitis media. We use the 445 laser. It's a blue laser, and especially when you work in the mastoid, where you know the bones are coming from beneath. It's like stalactites and stalagmites, and there are little gaps in between. You can really work and get that inflammation gone with the laser. Also, what we found is when we use the laser, we could save more the ossicles. So it's a rehabilitation for the ossicles. So with microsurgery, we had to get rid of more ossicles. We had to take them out. And with the laser, we could save them in 7 cases totally. And in the other cases where we had to take them anyway because the surgery, the cholesteatoma was so big, or the middle ears have been eating up the ossicles, there was no way. They also performed better. So this is one way for rehabilitation without hearing implants, but we're still working on. And this is a great way to do it, what we found in Lübeck, and we're still working on it. So this looks like in the OR, it's the blue laser. It's kind of fancy. So I think it's also middle ear guts very fancy and interesting also for younger residents to be cooler surgery and going on with the surgery. And this is something I brought with you to see why is it working? Yeah. Slow. Well, let's try again. Yeah. Here's the cholesteatoma. It's down on the oval plate. Schluck. We took the laser, sucked it out, and with us we could keep the ossicles in place. And that's very great for the patient. And also you don't have to treat with the oval plate or the oval window. You are always scared that the patient is going to be deaf. That's less risk if you use it. And the laser doesn't damage anything, what we saw. This is one point. The other point is cholesteatoma and the host pathogen interaction, as I told you, the inflammation coming and going. What is going on? Why is it coming back? Why can't we, with all respect to all our work, why is it still not, we couldn't find an antibody? So this is diverse, and we have to think where we can go. And as I followed the community a long time, I saw that that they used also natural plant-based therapeutics, and that's what we did too. So we came up with Soledum. Soledum, it's a monoterpenem, and it's 1.8 cineol. It's when you have rhinosinusitis, you take this. It's like oil, mint oil, and it smells like mint oil, and it works. So what we did is we just treated patients where we had no hope. These are the patients nobody wants, and we said, okay, maybe if you have something with the nose, if it's the one airway theory coming from the nose to the ear, and maybe then with the immune system, let's try and give them Soledum or Cinuol. So they took 3 pills for 2 weeks, and for some people it worked. Some patients, they really worked. And we have been happy because we didn't know any better, because no antibiotics worked, no surgery worked anymore, multiple surgeries. So I got the Cinuol, and we had physiological flora in the ear, and we could do ear surgery and even got him implanted with a vibrant sound bridge afterwards, which was helping him. Another patient the same, because we couldn't believe what we saw. It doesn't work for any patient, so I have to say, but for some people worked pretty good. So this person, he had a pseudomonas in all versions, 3, 4, 3, jumping back, forth, and he was super annoyed. So that was a really hard one, I have to say. And then we treated him with Signol and thought maybe something works. And finally, we could implant him with a cochlear implantation because he was inflammation free. And that's the main part. We have to think of conceptual treatment together so we can implant those people. We looked also in the microbiome, in the intestine, and we found those guys who responded to Signol, because not everyone, they had Prevotella in their stool. And once we treated them, it went down significantly. That's what when we published this. And we thought, okay, there's way more than we understand, and there's way more coming up if we look at the patients. And if the patient is inflammation free, for now at the moment, we have a wonderful portfolio, what we can offer the patient. We can offer him hearing aids if the ear is dry, but be aware of it's blocking, it's clogging, there's no air drainage. So what we prefer are the acoustics implants like the middle ear implant, vibrant sound bridge, or also bone conduction implant. They're wonderful methods. Even if the ear is a little bit wet, they can overcome the middle ear burden of hearing loss very, very well. And the final point is, of course, a cochlear implantation. So we in Lübeck and now we in Hannover, we use the newest middle ear implants like the Vibrant Sound Bridge, the middle ear implant, which we really prefer. I tell you later why. And also the newest models, the active intracutaneous bone conduction hearing systems like the Bone Bridge, the Sensio, and the Ossia. Why the middle ear implant and why is it good when you can use it? It has a good gain for against like hearing aids. It has a better separation between actuator and microphone. It bypasses the ear. So the ear canal is free, and it has a less distortion amplifier, and this makes it very interesting, and people love it. So this is how it looks. It's really small. That's on the outside of the skull base, and there you screw it on the skull base, and then you have this line, and this is the little floating Marstran's tool, so you can pin on different ossicles or anatomical structures for get a better hearing. And now you can see with the Vibrant Sound Bridge, you have a way more audiological preference to put on as the bone conducting hearing aid. So this is very interesting for patients with a combined or more severe, but not too severe hearing loss. And these are the different couplers. We call them couplers. You put them on the floating mass. And with these couplers, you can put it on the short incus process, or you can put it on the stapes, whatever is left in the ear. And that makes it very valuable. And I have to say, the surgery also is very cool to make. It's a wonderful surgery. So it's a win situation for everyone. So to show you that we also did a study for it. That's the study from Lübeck with Professor Bruchhage and the team. We had 42 patients. We had only put in their middle ear patients who had otitis media and had middle ear problems. And then we did surgery and put the Vibrant Sound Bridge on there. and we looked at the patients, how they do. And here you can see our results, how the vibrant sound bridge is wonderful. If you don't have ossicle, you can put it on the round window where you normally put in the cochlear implantation here. You can put it on the short incus or on the stapes. And it was safe, no problems at all. And also the hearing results have been really good. Also in age, like in little children, they profit, old patients profit, or also when you look at the different couplers, it's really full, but I just tell you in short, we used the different couplers on the round window, stapes coupler on the short process. So they performed, when you see this, from low to high, really good, and they're really satisfied with this vibrant sound bridge. And the satisfaction you can see here with the GBI score, and normally the 20 is already good, so it comes from 0, and 60 is really good. So they have been very satisfied. And also we have been interested in the microbial colonization, and we saw that the commensal bacteria was growing and the other bacteria have been going down. This means even after implantation, there was not a big problem. We do see sometimes patients who have recurrent chronic otitis media, but still the vibrant sound bridge is still working. So they have this episode, and once it drained again, they still can hear. So it's a great benefit for them that this is done. So these are just some pictures how we assess it. These are like sometimes complications when the anatomy is weird, but for every problem we can solve it, and we can find it over the facial nerve, under the facial nerve, which makes us a good progress. So we have this vibrant sound bridge, as you can hear here, and you have also the bone bridge. All these parts from the hearing threshold up to 55 now, they are also vibrant bone conducting hearing devices, as I show you now, or in the final stage when the hearing is really low, really severe, we can also use a cochlear implantation with a relative or absolute indication. This was on the Osseo in Wien 2025, and this is the bone conduction devices. To simple it down, we use those 3 because they are the newest, and I think not only cutest, but the best and smallest and the best processors. So the patients, they really profit. Otherwise, you can, in between, if you don't want to do it permanently, you can put a tier. It's like a soft band here, or it's like you can stick it on the bone, which works. But these 3 guys, if you implant them, they're working really good. So one is the bone bridge. You put it in here. You don't go in the middle ear. You leave it. Also, if you have several periods, or if there's nothing left, you put it on the skull base. You can measure it. Wonderful. There's enough bone to put it in there. You measure it with the software, and then you put it either sinodural or retrosigmoid. No problem. You can put it easy in with the screws. Patient is happy. It works really good. The other one, it's Ossia. It works with the piezo over this screw here. So the implant is here, and then you can put it here. So you don't have to drill a lot of bone, but the implant is pretty big. I don't like it for kids, but I like it for small bones, or if you have radical cavities or something like that, it's wonderful. The hearing results are wonderful after the activation. Some are performing not that well, but then they don't want to, I have to say, because normally if they're in there, it works really good. Another one, it's launched 2024. I want to just show you that they're the newest stuff. So you are on top of everything now here. It's 2024. It's the Sensio. It's small. You don't have to go very deep. You put it in the pocket in here. Really nice. The processor, as you can see here, the positioning. You just make here a cut. You drill a little bit. As you see, it's 3 millimeters. It's fine. You don't distract anything. Put it in here. Works really good. And the last one, it's when the hearing is going really, really bad. Really bad chronic otitis media we can't be treating at all, or several surgery, everything is out. We have to go for a petrosectomy. These are the patients, they can't hear anymore, they're not happy, ear is draining. So in this case, we are doing subtotal petrosectomy, as I showed you in the first picture, if you remember. When here only the stapes is here, the facial nerve is here to see. So the nerve is to see. So that's dangerous, and not that dangerous, but you have to be sure that you don't do surgery there. Otherwise, he's got a paralyzing stuff, and the whole inflammation has to come out so that it's going to be peaceful, and the patient is happy. And in this case, if this is done, we wait 6 months. And if it's inflammation-free, we can rehabilitate it with the cochlear implantation. Or if it's not that bad, I showed you, we can do a vibrant sound bridge. Both works well, but in case of severe cases, hearing loss, we can implant it. If we still have hearing there, as you saw at this patient before, we also use from metal. It's a robot arm who is inserting very slow, because we all know we are trembling a little bit, and so you can insert we can insert this very slow, and it's too long because we have to go on with this to keep and strengthen the rest of the hair cells, which is super cool. So we have a great variety in treating of chronic otitis media, and we have to keep in mind it has to be a conceptual treatment, conservative and anti-inflammatory, and rehabilitation in once. The ideal world would say, my aim would be, we look at the patient and say, oh, wonderful, we do one surgery, get everything out and restore. But sometimes the ear is blowing up, and that's why we do it in 2 cases. And for us, the VSB provides direct acoustic stimulation. It's great. It's more challenging in surgery, but it's great surgery and gives the patient a very high satisfaction. The bone conduction implants are more simple. They have low risks, but they're also very good. But of course, it's not direct stimulation. But if the brain adapts after some time, it works very well, I have to say. And in the end, if you have a severe hearing loss, you do a subtotal petrosectomy if there's nothing else left, and a cochlear implantation in severe cases. So the goal for us is to personalize, to do personalized medicine. We hope to personalize the diagnostic with either OCT directly in the OR, so we can say, hey, this is just a small portion, we do directly an implant, or for sure we need to do it in a second time. And then we have personalized strategies, whatever is good for anatomical changes or varieties, or compliance reasons or ages reasons, because like a bone conductive hearing aid, like the Ossia, you can do it in local anesthesia when the patient is holding the head still. So there is going to be more and more personalized surgery. And with this, I want to thank you. and thank the team and everyone. And also thank you, Reggie and Alan, letting me be part of the Otitis Media family, which I'm really grateful. And I'm looking forward next year to the Philippines.
That is so awesome, Anka. Thank you so much. Yes, I forgot to mention you are a COMMeND mentor and you have 2 mentees in our network. So thank you for that. I think you're the only one in the world who puts together microbiome, a new anti-inflammatory agent, and then surgical implants. I don't think anyone has done it that comprehensively. So congratulations.
We give our best, but we still, I have to say, whenever we find something new, there's another question. So it brings us to new ideas, which keeps us running. It's good.
Yes. Anybody who has a question, we can probably accommodate one question or comment from the audience live. Okay, then. Well, thank you to all our wonderful speakers. I really appreciate all your inputs today. This has been a fantastic webinar, totally exceeded expectations. And I want to share one announcement since Anka already mentioned ISOM. I'll put it up. I'm sharing my screen. Here we go. So somebody requested for topics. So I want to share. This has been a group think list of topics for abstracts that we will start calling for in November 2026 for the, as Anka mentioned, meeting for the International Society for Otitis Media in Manila in June next year. So I hope that you start thinking about abstracts. And you can also send your mentees and spread the word so we can have a really fun meeting next year. And then I'll stop share. I also want to share that our next webinar will be on animal models. We have speakers. Alan will be speaking about his work over the past how many decades. He's really our role model for otitis media research. And we also have Stephen Brown and Seb Koryoglu from Minnesota. So we hope to see you again in the next webinar. Again, thank you for joining us. Have a good day.